invite Dr. Dheeraj Kumar on stage, Dr. Anish Kumar, Shri Nandish R. Pithani, Professor Dr. Bejanti Mala Mishra, Professor Dr. Manoranjan Patnaik, Professor Dr. Prashant Raghav Mohapatra, Dr. Argya Pradhan, I would like to invite Dr. Dheeraj Kumar and Dr. Anish Kumar to moderate this session.
Hi. Good afternoon, everyone. One and all present here. I think we had a wonderful 1.5 day interactions on different challenges, opportunities in TB diagnostics, how we can strengthen it. While we will try to reconcile things that has been discussed, we'll also look into the possible roadmaps which will give us directions that how Odisha can really lead this targeted NGS as a pilot mode, which, let's say, if succeeds, can be used as a model to take forward to different parts of the country. We have questions on, how to strengthen the targeted genome sequencing, how to ensure that samples are collected and transported in a proper manner. That was again one of the points discussed today. Are there ways for digital tracking? How do you do the public health management? How to bring all the stakeholders together to ensure that there is a successful implementation of this targeted NGS, for UDST or tuberculosis. And we all would agree that the purpose of this interaction right now is to hash out, any point that we think we need to discuss more, to ensure that we have a clear roadmap that how we can really take this forward. We don't need to really re-emphasize on the importance of ANPS, the resistance. We all understand it. We have, over and over again went through the process to understand challenges. So, what we will do is, I think you want to say something, we can begin with some points. Okay. So, we can begin with the technical perspective, that what are the technical challenges, and given the current scenario, why this is the time that we think we can start UDST path in Odisha, targeted NGS, and your thoughts on this.
So not just in Odisha, I think it's all over the country. This is required. I think that's my point of view. Now, why? And of course, this is something extremely new and extremely new technology. It requires a lot of training and validation of not just the technology, right? So it's actually the easiest part is actually to have the technology that we can. So there is no doubt about it. We can actually sequence thousands of whole genomes in a year or two. So it's not a big deal actually to do that. But there are other challenges associated with it, which we'll come to later. But right now, the important aspect is we need to be clear about what extra are we going to get. See, for example, when we were talking earlier with many others, one of the point is what we are using today, which is Gene Expert or NAT based, right? I mean, if you look back, several years, probably when they came, that was also probably not easy. From looking at the sputum to move into the molecular base, which actually looks at the mutation, right? So that was not easy either. But we did that, and we know that how much it helped. Right? When we compare how it was from 70s or 80s to what it is now, there is like black and white difference, right? So, but now I think is the time that we look forward into the next 30 years and see, by doing only what we are doing now, are we going to reach the kind of difference that we made in the last, that progress? It's not like plateau, right? The progress, are we going to maintain and reach to the next level in the next 10 or 20 years? That's what actually we have to be really looking at. And for that, I think the genome based assays will be the most, and it will improve. There are some discrepancies will be there, but over a period of time it's going to improve. So ideally we should have what we have now, and at the same time, like in states like Odisha or other states as well, we should have these pilot studies which will address all the logistics and all other aspects associated, because only when we do this we will know many times that what are the challenges that we are going to face, right? So we need to really get into that to drive us to the next 30 years. So that's my concept. It's not about replacing what we have now, it is going to the next level.
But yeah, I think that's a good way to start this discussion. But whenever you adopt a new technology, so that comes with its own challenges, right? Probably when Gene Expert came and CBNAT came, it had its own challenges. Some of it are still persisting at probably remote sites. This UDST at TNGS is a next level of challenge. A little more technically demanding than what Gene Expert was. So considering that, what should be the set of steps that one should plan so that TNGS, UDST can be easily adopted even at the pilot scale without any hiccups? That's something which is your views on that.
Yeah, I mean, it's going to be extremely challenging, right? So because Dheeraj is also aware, and that how when we were doing the in TGS itself, we know exactly what are the kind of challenges that we can get. Starting from getting the sample, transferring the sample to the testing centers, right? That in itself is a challenge, because to make sure that you maintain the quality of the sputum samples so that you get enough DNA and to really do the sequencing. So that's a huge challenge. I mean, it sounds trivial, but it's not trivial. That's actually probably going to be one of the most bottlenecks for this whole program. And second aspect is the sensitivity, in the sense that we have patients with different loads of bacteria, and there are and this particular method of TNGS, though it's highly sensitive, but still there are limitations in what is the minimum number of bacteria that you would need to actually amplify and get a signal. Currently, I think whichever the kits that are approved by even WHO need to have at least grade 2 or grade 2 and above. So that is what is really required. So that's a challenge too. How are we going to bring down sensitive, increase the sensitivity to detect even lower levels of bacterial, load. So even that's why it's also important that we cannot get away with the TrueNAT or the NAT studies, which actually quite efficiently pick up the infection. That diagnosis part is already there, but the DR part, how do we actually bring that sensitivity down? That's another major challenge that we will have. And third part is, which I think is a matter of time, just a couple of years time probably, is the technical aspects of doing the sequencing. In the sense that that's slightly more complicated, but it's not extremely complicated. Anybody with a regular lab experience in regular PCR can do that, right? But still, there are steps that can produce variability. But if you are following the whole sequencing scenario, we can see that over the last 10 years, how the sequencing has become more and more compact and more easy. Like 10 years back when we did sequencing, you need 2-3 different machines, and then finally throw a prayer to make sure that it actually runs. But now it's extremely easy. Right? You just put the library into one cartridge and forget about it. So soon that technology will develop on its own. In a couple of years, it will become even easier. So I think that will not be a big issue. And third thing is about the analysis. That actually probably the easiest thing, because now there are very good pipelines which can take out, and even the kit producers themselves have pipelines which can take the sequence and give you a report. So those two are probably the easiest part. We will have to really work on the logistics and on the sensitivity issues.
Nice, thanks. So you covered two very important points here. One is that the existing gold standards should continue, because we still, the new technology hasn't really advanced to the stage that it can cover the extremely low bacterial burden cases. So that's a very important point that we have to remember when we design the pilot, that that should not complicate how you interpret the results. The second, which you kind of refer to towards the end, that when you have this genome sequence data, which looks very fascinating to look at these many mutations and all, but they should be clinically informative in the sense that it allows you to take clinical decisions, that is, these are the treatment regimen that one has to start. So, I mean, you kind of alluded to that there is technology which is available, that sequence data can be, immediately analyzed using existing pipelines, and you can get a pattern. But how practical it is that, let's say you get a sample today, you go through the TNGS sequencing. I mean, what would be the turnaround time that you come back and say, these are the drug resistance, and this should be the regime for this particular patient? So, what's your thought on that?
I believe we should target to, from sample, at least sample reaching to the laboratory to the report in, maximum 48 hours. That should be our target. That should be the end, the dream. That should be. That I think is achievable. That should not be a problem. But the more important question is how this can be used by the clinicians, and especially now we are also dealing with not in a big city or in a hub. We're also talking about primary health centers and such places also where everything may not be as accessible. At least from the report point of view, there are multiple options. One is regular PDF report that can be sent to. But actually today, Rohit and I think Ms. Pathani as well was telling about apps. That's a wonderful option that we have. If the PHCs, if they have an app where they can say this is the mutation profile, which should be able to pick up a personalized regime for that particular patient, so that there is no need to, that can be centralized as well, right? So if you have this particular pattern, that patient should get this particular set of antibiotics. So that can be easily achieved now. We can do everything on phone now. So such an app will be probably the best way to I think go forward to disseminate the information to make it in a clinically usable form.
Yeah. Yes. So turnaround time. So that part I think. So I think 48 hour. If we recollect what Rohit was saying, that if you get the results in 48 hours and you know what to give or what to give, that makes a huge difference. And
so we are not going to make it in pilot, right? So that we can be sure about that. But at least we will know how to make it in the actual in a couple of years from the pilot. So that's what we should target actually.
thanks, Anis. So we'll move on, and I'll have a couple of points from Nitish ji. Coming from the Policy Resilience Foundation, I mean, you talked about what policy is, right? Idea and action, right? Followed by action. So, how, I mean, we had wonderful discussion over last 1.5 days, but how we take this conclave into an actionable plan and where PRF gets into this.
Yeah, thank you. So this is something which is our intention also at PRF, that whatever we discuss here today and whatever we are deliberating, can this proceeding of the event be a action mode pilot project outline? Can we come out with a concept note or concept paper that this is how we can do, this is how it was discussed? So I can give you a precedence of the state of Assam. We had the similar conclave with the AIMS Guwahati, and Honorable Health Minister of Assam, Singalji, also presided, and then Commissioner and Secretary Health was also there. So there we came with the conclusion that AIMS Guwahati becomes a nodal institution, and 2 districts will be suggested by Government of Assam to AIMS Guwahati, and they will plan a pilot project of doing TNGS of at least 10,000 samples, known cases of DRTB, also unknown cases of DRTB that clinicians will take a call. So for that a steering committee was made, which is majorly presided by the doctors from AIMS Guwahati, and they will decide the SOPs, protocols, the actionables of the pilot project. We calculated the man hours, resources, existing facilities available with the AIMS Guwahati, the kit cost, and all those consumables which will be needed to do a pilot. When we came to one number, we decided that since this is a little long program, so the time frame for the program came around 12 to 16 months. And the discussion went up to the extent that the steering committee, one of the representative also was from Government of Assam and majorly from the AIMS Guwahati. So why I'm giving you this precedence, so this project is under final submissions. The fund has been, it has been decided that the fund will be given by the development partners like Gates Foundation. We are also one of the funding agency. And this, as we are all discussing right now about converting our thoughts into pilot, this precedence is already there. We haven't started the project yet, but majority of the submissions of the projects has been done. So how do we convert this is almost in the similar nature, that from the proceedings, the team here, all the experts sitting here, are the people who will take a decision that what can be the potential roadmap where we actually focus on doing this. There is no certainty of getting success, but what I could understand from the policy lens is the result that the NGS is going to give are definitely going to be compared with the culture test, which is the gold standard as of today by WHO. Even for NGS, if I'm not wrong, the repository is open for public and researchers by WHO. So there is a gap that somebody needs to take an action there. See whether it is okay, complementary, whether it is failing, whether there are problems, whether we are claiming that turnaround time could be 48 hours, are we able to do it in 24 hours? Or are we able to do it in 3 days or 10 days? No, if we do the pilot, we'll come to know. There are chances of failure also. There are chances of failure in the anticipation also. So just to get the trust and confidence into the results, this pilot program has been shaped up in the SI. Almost in the similar nature, I believe that with this conclave's proceedings, we can form the concept group, followed by the in-principle discussion with the government, and then the TB officials are also here. You all can discuss, deliberate, and submit a proposal that can we do, because it's a state subject. So before we do any pilot, we need a permission from state. Although we're not seeking any funding, but we still need a permission from the state government that we are doing this kind of project. These are the SOP, these are the people. We become their digital backbone. So whatever in terms of digitization they want, monitoring tools, we'll develop it as part of our philanthropy and contribution. So I hope I'm able to get more clarity on this.
Yeah, certainly. But the little bit more on the the financing part, because this is going to be I would say fund intensive exercise. Where it is, how big we are thinking about.
So I can tell you in the financials, because it is under submission, so I have a little limitations to go beyond the point. But for certain, there is no upper cap as of now. We would essentially fund the OPEX, the operating expenses, because our mandate doesn't allow us to ask anyone to buy machines from our funding. But we can buy kits, we can hire the human resource.
So this idea is very important. I think you explain this OPEX versus CAPEX. I really like this. The way people can make things happen without investing a lot on developing the capital and infrastructure.
Yes.
Rather than looking to the results.
And this project also, sir, I would definitely debate on this. We want to push a model which is OPEX based, not CAPEX based. What does that mean? That means in COVID, everyone got tested. And if anything has to be paid, you pay per test. You create the systems of monitoring, you create the systems of surveillance that no fraud or no fraudulent practices happening in that. But essentially, you do not invest into the machines. You are not worried about the cartridges. You are not worried about the kits. You decide this number of tests I want to do in the district. You achieve that target, you pay the vendor. Has to be very clean and clear in terms of process, which is OPEX based model, which is also part of our pilot this time.
Yeah. Thanks, Nandiji. And
civil aviation suggestion is different. I think we should take go through the projects, similar projects done elsewhere, and what are the problems they faced, what are the shortcomings they have, and the committee should be uniform, and the higher committee should uniform and look at. Because once in projects, after taking the project, you cannot change the methodology. The methodology has to be very robust and should be actually much result oriented. Unless you review the other project, what problem they faced. So that has to be, I think, it's not, again, it should be uniform both the states. If it is possible, it's both the states. So the data can be accumulated, comparable.
Right,
so otherwise, you cannot have a different methodology for themselves and who have different.
I think that's also
technical aspect is more concerned.
Yeah, where the aim to UNICEF and state government, the TV control department. So their inputs become very important. How you plan.
I think your input also important, because technically it has to be robust.
That's right.
The methodology has to be robust.
So the point is methodology in terms of doing the TNGS, and Anish will add to it if I miss some point. It's kind of very robustly established now.
And inclusion criteria, exclusion criteria,
exactly.
Which patient we are going to take,
So
which person going to include it, how do a subgroup analysis, what groups we are going to take. I mean, these are what are the age group we are going to take, what are the type of sample you take. That is also more important.
Absolutely.
Because it's all depends on all this input.
But sir, right now we are at concept stage.
Sir,
so
that's right.
as I said, It will be the clinicians who will decide the SOPs. It will be the people who are working on ground writing the prescription will decide the SOPs. So we are making very clear that policy, we will not venture straight away giving a gyan, oh you do like this. No, no, no. Let clinician approve it. Let larger population accept it. Let patient get benefit. This is all documented. Cumulatively we'll take the call that yes, now we can put it as a policy.
Yeah, no, absolutely. That's very important. That's why I was saying that local role becomes very important. And for this program, I totally, I believe that the larger goal of this whole policy dialogue and getting into the pilot mode is to align with the PM's vision that we have a Bharat in the next 4 to 5 years time. So, anything that you want to add on that?
See, I can definitely say that any effort that we are planning to do, whether we have started doing it in Assam and we are planning here in the state of Odisha, we are strengthening NTEP. That's only intent. B, there is no parallel tech platform. It is only Nikshay Mitra, which we want to strengthen, reinforce, give more data, create the additional plugins at the state level, district level, at pilot phase, so we can have a more clarity. Because Honorable Prime Minister's clarion call on TB Mukt Bharat is actually a collective call. Well, now the action is needed. Government has definitely is doing and is planning to do more and more. But how do we, as a think tank, we call it so-called think tanks, we cannot just keep doing the conclaves and keep sharing the reports. We have to take little step forward, which normally the think tanks hesitate to do because there are chances of failure. There are multiple stakeholders. There are chances that somebody will disagree at the middle of the project and your project is gone. We are funding, so we are also accountable that why this project is not happening. So, despite of this risk, at think tank level, we decided that we'll do pilot project, only to reinforce the existing system. And I know that it's Honorable Prime Minister's clarion call, which is received so well, that this digitization and health has shown wonders during COVID, has wonders in transparency, and almost the similar nature of communicable disease problem. We want to create the solutions for tuberculosis. So, very clear precedent set is there from Honorable Prime Minister's vision, his thoughts, and now it's call for all of us to take the action.
I think COVID response has kind of instilled the belief that nothing is impossible and Indian health system can attain bigger things and bigger objectives. So thanks Nandishji for your views. I'll move on to Professor Vaijayanti Mala Mishra. So ma'am, being from AIMS Bhubaneswar, what's your thought in terms of how this institution can contribute toward this genomics and microbiology of TB research in the context of targeted disease?
Yeah, I think AIMS Bhubaneswar has a lot of potential, and we need to explore or we need to think, as Sir mentioned, we need to actually brainstorm how exactly we need to utilize our potential. Because this is something, it is not only the sole responsibility of any particular institute or any particular, one particular stakeholder is not there. So AIMS, suppose, if I say in a very simplified manner, suppose, for example, AIMS will perform the test, like it will work as a hub. Then it has to have a very robust integration with the state health authorities. Because as we discussed, the sample coming is the first step. So integration with the state health authority and which are the districts we are going to choose, or whatever is the basis it will be selected. So that needs to be worked out, and a very robust integration with state health authority should be there. Now, technically, yes, it can be done at AIMS Bhubaneswar. And besides that, also, like it can do the hand holding of training, the quality validation, quality assurance, because these things are ultimately important. And also like maybe I think even the company also can come up with app in 1 or 2 years. That we have seen with many of the automated system, whether it is for example, Vitec. Vitec is a system where it gives the identification and it gives the image. So like that, I think the kit which has come up, the platform like Illumina has some better this thing for TB, what I know. I have not used, but uh, I think those platforms, they themselves can come up with the app which can tell even the last part of the story, that after analysis, how it can help the clinicians. So from starting point to end point, AIMS Bhubaneswar can play a pivotal role in this.
That all the initial sequencing has to happen in in collaboration with James Bhubaneswar.
Yes,
That's the best way it can happen. Samples come. Is that you work the microbiology competition and sequencing infrastructure.
logistics.
And so yeah, so I believe you have quite a few of it, but exact state.
Logistics is definitely important and require is for any operation. Be in terms of equipment, yes, AIMS has equipment, the NGS we have, though not specific brand of Illumina, or I don't know, maybe some other department has it. Even in microbiology we have it, it's yet to function. Not Illumina, but some other brand, but it is there. All NGS, they are high-end equipment, and every brand is good enough. So that is there. But yes, as from the project, the kits and everything will come, and training is very important. Training to operate the machine, to do the sequencing, and training for the bio to analyze. I think you will agree with me. So analysis is very important. Though yes, some platform again has very good analytic analysis tool. So those logistics are definitely required, and it's not something not doable. These are quite feasible. Yes, and in a Premier Institute, and we are not one of the new AIMS, we are one of the old AIMS, the first generation AIMS. So by now we have so many things like sequencer, and even running the TB lab for so many years with so high number of samples. So those things are there, and a very good clinician's input, be it medicine, pulmonary medicine, pediatrics, even extra pulmonary. It's we can't, it's amazing. We give positive for, we get lot of colon tissue, we get lot of synovial fluid, and they become positive also. So that in the initial part, people used to think that chances bahut kam hai. Chances come hai, definitely in possible cases. But when they get positive report, then they send more and more. So we get a lot of EPTB positive for this rare and very minute amount of sample. Of course, on those cases, we put more effort how exactly to process the sample. So those expertise we have excellent group of clinicians who are interested in their TB patients. So all these kinds of logistics, starting from equipment to the clinical expertise, of course, microbiology expertise, everything is there. So it has lot of potential and many things can be done. Yes, AMR surveillance, we were there in one of the CDC project. One of our faculty was there in one of the CDC projects. So that keeps happening, AMR surveillance, and a lot of centers are there. And as far as TB is concerned, already we are like NAT testing center from the program point of program side. But besides that, from our institute side, we do many things extra. As I told in my talk, we are doing like CVNAT and TrueNAT we do from the program side. But besides that, we are also providing culture facility, we are providing the LPA facility, and so these things are there. In fact, now one of the other beauty is we inform the clinicians even telephonically, look your patient before we had the lab informative system, the HMI is in place. We used to send them email, and we have our own WhatsApp group, so that it's not that 2 hours stat. That is the component of the machine. But we also put the extra effort to inform the concerned clinician at the earliest possible time. I think whoever clinicians are there from AIMS, they all will agree with me. So that also needs to be done if NGS will be done. So it is not, the story doesn't end with the result output. It ends when the treatment goes, exact treatment goes up to the patient level. So that channel also is important. Yeah.
So fast negative side. So fast negative side, I would tell, because M's potential has got around 40 years. Right? So I have tried for the last 8 years to build up a DRTP one. Several letters of two directors for a year, zero resistant genomic search most of the past half a break. There must be MDR1. Without MDR1, hopefully the state. Yes. So we get the next first, and this is the first. Second, we come to the ground level. We go to the village level, ground level. Because I have last 15 years in teacher. I am actively involved in the program. I am also a task force member of medical college involved in that. I actually initial the stage has been very poor condition. The performance is very bad. For last 3 years, we are the first number one state in the Eastern Zone in the TB performance as well as out of 6 states. Odisha performance is the best performance out of still the UTSD is the worst. Odisha Eastern Zone and Northeast has got the UTSD worst. North 90%, West North South is 90%, East West and North is just 90%, but you will see Northeast and East. Yeah, I am coming to that. Yeah. That will help for you also implementing the pilots. So you come to the patient. We'll start with the patient. Number one patient when coming to the physician, the physician advice for sputum, there is a delay to present with the sputum. Number two, there is usually sometimes suppose a patient has come to AIMS or AC medical college. So he has come from a distant place. So without he has to go on the same day. We are asking, we are not giving a emphasis on the small samples. 2 samples on the same day. We are asking for 2 samples. So on that basis, patient is going back. Once he has gone to that side, so patient are losing for another 7 and 10 days, the symptoms is increasing. So in that issue, we have to take necessary steps. When the patient department, immediate 2-step samples should be done. So no patient should be left without collecting 2 samples. This is also mandatory for also other things that may not be for DRTP, but it is one of the samples, number one. Number two is suppose the patient has got a seminar positive or NAT positive. Problem is that the vaccine is 90%, but isoniazid 30%. So LPA, first line LPA and second line LPA, there is a very less thing. But I'm told that training and returning. The concept of NTP is always training and returning. Without training and returning, you cannot achieve your achievable goal. Yeah. That LP is a must. That is a laconic. We are laconic oil. Before that, before that, must the absolute thing is that we must implement. So on that basis, you can do the operational research. Because the treatment for this, because CTD will not allow to integrate immediately. That is the will not integrate. Yeah, the operational research. We can do the operational research and what the post data. As far as country, so the clinician, this is this. This is 1 plus 1 is equal to 2. You cannot go for the 1 plus 1 is equal to 5. Straight away you find out whether it can tell 1 plus 1 is equal to 2 or not. That can get from our operational study. One thing about Assam Bioma is your duration is a dual system. Yes, system. You are taking 2 districts. Yes. How will they 10,000 samples? It's not possible. I think I was in the Cuttack. I think we must work on the progress because priority would be in the progress, not to the. We'll go by the NAT testing is go by the NAT. But there is listen, one thing you are debating the clinical risk. Unless you think there's a drug resistant here, how you take the all samples of the yeah. Well, since suggestive of the drug resistant tuberculosis, you take this. Not everybody. Yeah.
That's bigger than. And recent study, neighboring study, what happened to Australia also, they were 42.7%. It's supposed to be the RR, right? Similar. Becomes sensitive. Okay, becomes sensitive. Then what 43% as a resistance mutation, and these resistance mutations beyond the standard RRT. That means our aim is to take a proper general sample, good sample, then you are going to get upward resistance. If you look at this India data, the country doesn't have more than 60,000 data every year. So where you get sample, you have to take a sample from the population, and this should be population-based data, and I think it's give a data in a database or further suggestion for YTD or whatever government of India is doing to control the tuberculosis. Unless you find out the upward resistance, so treatment failure will be there. That translated to patient here, I'm not very sure. What is happening in the long term now we're something like targeted research targeted 12 now 12 पहले 180 milligram but EGFR that consists of 19, 18, 19, 20, 19, 20, 21. So that's one. Now it's giving 12 in panel. That includes 11 other panel. So what is happening? There is a trial for every mutation. So I think all mutations should be differently taken and different aspects. The outcomes should be taken. Whether they really need a treatment or there is that resistance is not really going to change the outcome. So there are many resistance. Even if lung cancer were getting many mutations, they don't have a drug. So it is our target is to if you get a rare other mutation, then can you develop a drug? That is our future plan. something you get this, CR is something this. So something you must have a plan to develop drug for against that mutation also.
The thing is that it's a program condition. Tuberculosis is a program condition. We can go beyond it. Beyond it means we must have some regimen. Everybody cannot. Why drug-resistant tuberculosis is there in India? Because your study, Bombay study, 300 types of regimen is existing. That is the cause of the drug resistance. The Bombay area, the highest drug resistance because of 300 types. So individual when you are getting the resistant panel, so they will allow the physician to take the call on that way, then there will be again those second line, those group of drugs, there will be. So India government has to formulate the regimen which can be public health wise, can be even to the periphery. Everybody is not a pulmonologist or medical college pulmonologist. So
Yeah.
from the project point of view, it's all right, but the implementing in the is very difficult. Even to formulate the regimen will be very difficult. Yeah, tuberculosis mortality. So actually, what how to find the now the with the better regimen, medical regimen, the cure rate is around 72%. Even if the BIPA regimen, if we are not giving to the BIPA the extensive disease first patient, but in that there will be up to 84, 89, 90%. So those patients who are not taking medication, where a defaulter, the death rate is. Otherwise, the group, whatever the drugs we have now, is very good drug for the treatment point of view and not the point of view. message to them. So here it is the nodal center. So from the different medical colleges, my colleague, you can call and train this on this basis of that. That will again almost now there are so many medical colleges every district are considered. About the district also, the medical concern medical will take care. So we have to decentralize the training. Only coming to the aims for all the time training is not possible. Because they have got a lot of work. They have got a research work. So for this training, there is a master trainer. They will create a trainer who will be verified. They will give the training to the patient. That will be the ideal.
Training of trainers.
Yeah, training of trainers. Good.
Overnight, I wrote a letter to HR for the next 2 months. So I will oppose that one. But it's more of a scientific feasible study. Then European Society, I went many times to the manual of the give us a seminar to to us. He supported the idea. But again, what we need, what we thought, but actually situation gone differently. So what I mean to say, what that time also, in country like America, Europe, they have any 3% of it has to be gone in CSC. That more than decades back. So what we are going to follow, literally we are going to follow what the scientific need of the country and scientific need for the patient. What actually needed for the patient is, so it was, something come, like the FDA come, it has own issues, and CBNAT come, it has own issues. Now the NGS will come, it will tackle some issues. I think maybe 10 years there was something ahead of that. So we have to adopt the most advanced, most accurate, and which is beneficial patient and which can get a better outcome. And the outcome, what it is, so the people, what are the trial condition? Trial condition is from real life condition, pragmatic condition. I think this is something that I will begin this treatment. I will program condition. The real life condition is 50%. That will not take the it's not away from the convincing is this, but it is achievable. Trial condition is practically.
Can I say just a few points? One is regarding LPA, as sir mentioned, we also discussed. Now that we have that XTR cartridge, we should go for XTR more rather than LPA because LPA is technically demanding, and though LPA now says that it can be done from smear positive sample, but actually preferred is the culture. And the moment culture comes into play, the turnaround time is there. So that is the problem with the LPA. And LPA requires actually too stringent condition, and sometimes it is subjective also. The band you have to see and all those things are there. So now that we have XTR, we should move on to XTR rather than like LP. That is one. And second is, as sir was saying, the program point of view. Program is always sees the majority, how the majority will be benefited. Now, if you see the polio example, initially it was the live vaccine. And we used to say the advantage. What is the advantage? The vaccine spreads in the fecal matter, and the unhygienic thing is rather a boon because the vaccine spreads. And when we come closer to eradication, then it switched over to the inactivated polio vaccine. Like that, the more and more will go closer to reducing the TB burden in terms of positivity, in terms of resistance and whatever. We should, now we are, as we are seeing the NGS, now the road of NGS is high time, should be implemented in parallel whatever is going on. And that will really solve the puzzle, because many cases, as I also mentioned, and many of you mentioned. Yeah. So, yeah. Yeah, no, more and more closer we are achieving the towards goal. NGS role is definitely there. Yes. Yes.
So, what do you think about the implementation? How we can implement the pilot program? Like what we have said in Assam, research. What is the most feasible way to implement it? How can we make also people accept it? Implementation as well as resolution, accept this kind of project.
Technical part already has been discussed in detail. Coming to the implementation part, where the necessity of the program delivery. So coming to that, first of all, when we are planning for that pilot level implementation also, we have to ensure that that whatever we are going to do is operationally feasible. First. Second thing is, after operational feasible, we have to see that it is scalable. Because if you are doing it in operational feasible in a limited area, where everything is in good shape, then because this is a diverse state, the country is diverse, and while you are scaling it up, there will face lot of challenges. We are facing that similar challenges regarding LPA, hostile LPA samples collection, starting from collection to transportation, then issue of storage in laboratory, IRL, then testing it. So that turnaround time becomes very high. I told yesterday that is why by the time we receive hostile LPA result, the treatment has already been completed in the one of the cause of false negative. So these are the operational main challenges. So we have to see that everything we should not over and first. And one more thing is that it should be in alignment with mixed because we cannot go beyond mixed. Because for NTP program mixed is success. Whatever reports come from mixed that is acceptable. Beyond mixed, nothing is acceptable in NTP. So whatever we are going to do, that has to be in line with the mixer, and every data should be synced with mixer, and we should also ensure that we are not using multiple apps. Because I will give one example, cite one example, because Vadhwani developed 3 AIs in India. One AI is that prediction of adverse TB outcome, one is this vulnerability mapping, third one is top sound surveillance. Top sound surveillance, when they asked us to implement in the state, we have tried to do it on pilot mode with 3 subcenters. And we try to evaluate whether it is actually feasible to do it in field mode. And we found that we selected 3 good community health officers, and they told us after 3 months that it is taking a lot of time in that time. And again, what is happening? They are doing some recording in app. Again, some result they are again putting it in Mixer. Again, that Mixer ID is being generated in Mixer. Again, they are bringing the Mixer ID to this app. So, entire process is taking 15 to 20 minutes for a single presumptive TB case, means a suspected TB case. So that was so we have concluded that it is not operationally feasible and not ideal to scale it up to the entire state. So that thing also has to be kept in mind while deriving the SOP for this project also. These are the some few things. And again, these workers in TB program are extremely overburdened. So we should not still overburden them with the additional work. So we should not expect that some additional work has to be done for this process, because if they are collecting samples, they can collect another sample for this PNGS. So we are ready. So, but while doing the groundwork, we have to ensure those things.
Okay, this is really valuable, important suggestions, to keep in mind.
Have our own people to collect this putam, not if we are going
Yeah,
for
I
the
think
operational board,
I think those operational details.
because you are
I
taking
think,
2 districts.
I think those operational details will be, charted out later with Nadeshji and everybody concerned, I guess. Yeah.
Because one thing because I have worked also on the silicosis, to get those putam and involve them is a very difficult job, right?
So now coming to Pradhan sir, Nandiji has been talking about the form of financing, right? It's not like documentation to everything. So what do you think about that integration part?
No, that is not new to us. Actually, we are having this project is fund, and TEP comes under that umbrella of National Health Mission. So major chunk of fund comes from NHM, that has state and central share, leave it apart. Then there are different partners also working with us in different sectors, starting from family care models to we have differentiated TB care model, different TB models. We are working in different districts, and for a same project, different organizations working in different districts. There is overlap, but there is having also some financial support from those side. So those supports are operational supports. So similarly, as you have already told that you are not going to give capital expenditure for this. So a capital expenditure for the capital expenditure, if you are going to do that for the testing of samples, then you have to ensure that wherever we are doing it, this facility is having that machines or equipments, or those machines or equipments are not, they're relatively free so that these samples can be tested. That is a challenge. Because when we did some study in some areas, we found that as we are those sending samples, these machines are overburdened, including HR. So they are not able to process those samples in time. So that is a challenge. If you are not giving capex in those cases, there will be a challenge. Then coming to, and again, while scaling it up, there will be difficulty when you will be expanding it to the entire state or something like that. Then coming to operational cost, we have to see that if some, for example, transport, sputum transportation, it has already been taking place. They are bringing samples. So in case of 2 samples, they will be bringing 3 samples. So that may not cost us. But if they are bringing it separately for this purpose only, so it will cost. So that has to be taken care and accordingly planned.
So
I think you have mentioned very clearly, which is I really appreciate, because for any of the overlapping, definitely a for capex particularly, I will say in terms of capacity, we did little homework and we identified that during COVID who had raised their capacity, but still machines are lying idle. We are talking about only institutional capacity. So, and the beauty is that once we start mapping it, you'll be surprised that there is a capacity available. But what is used to happen? I am yet to finish for Odisha. I am hoping that it will happen. But what was interesting is some institutions are also waiting that such project can come, they can collaborate with us, and their machines are also put to use. So I think we will definitely ensure what you said very meticulously. And in terms of need of the capex at a point, definitely we can extend that support, because ultimately we want to complete the whole project and whatever is needed, but emphasis is on the opex first. And a second thing about in terms of the governance, so we want that state government and aims becomes the steering committee. They decide what is right, they decide from ground what is to be picked up, they make a final decision of what should be the SOPs, protocols, but not necessarily we are aiming that we'll get success. We are prepared for failure. We are prepared with that immunity of failure, that okay, OPEX, while we do, there would be some challenges, there will be resistance, there will be you and cry a bit, but then that openness is there from our side, that we can sit with you and understand the problems and solve that first. So I hope we are clear at the pilot level.
Yes, yes.
So now, the final question: so for any project, right? For any project, whether it is pilot or any project, we should have some indicators of success, right? No, or at least we need to judge it, right? And then based on that, we should be able to say that yeah, it didn't meet these parameters, it didn't meet that. Some places it worked out very well. Then only we can go forward by changing or adapting and etc. So, what do you think should be the indicators that are, that we should have, using TNGS for uh, helping people with tuberculosis?
So basically, there may be process indicators, there may be output indicators. So process indicators will be the inputs. Based on those inputs, how many tests were conducted, how many total TB cases notified from that block or that district? How many of them has been sample has been collected from them for TNGS? So that comes under your process indicators. Then output indicators may be those patients initiated on treatment, then the regimen change, converted to one to different regimen based on the TNGS result. Because as I have already told that many a times it is not happening actually because of the delayed turnaround time of our those first line, second line LPA samples getting delayed. So if TNGS gives it in proper real time, means within 48 hours, as you have already told, that so many in many cases it may so happen that that regimen change will take place. So that can be calculated, and it can be compared with other districts also. So in implementation district, it is taking so much, and the reduction in death rate of those diagnosed DRTB cases, because diagnosis is early in DRTB, so outcome will be definitely better, and regimen is proper, so that the death, the cure rate as well as the reduction in death rate, those can be calculated,
So,
and then those can be the indicators.
So do you think we need to compare these results with the 14 drug, phenotypic DSD, or we should use the existing, strategies, which is basically gene expert or similar strategies, and compare that and the used regimen with the TNGS?
That can be answered by
Right.
Naik.
As of now, we cannot change the regimen.
No, we're not talking about changing the regimen.
Compare the testing.
Compare to,
Ah,
comparison, you can do the
Okay.
gold standard is the culture.
So,
You can compare also your result with the NAT testing also.
So that's my question. Should we compare our results with the NAT testing, or should we do a 14 drug phenotypic DST for all samples to compare them? That's my question.
Only compare.
Huh.
But we are limited to that. But not.
Yeah,
not
that is clear. That is absolutely clear. The question is, what should be the comparison? Should it be the phenotypic DST or the NAT comparison? Oh, okay.
Because you see, every technique has its own limitation. If if you see the comparison of any new technique of TB also, when you compare with culture, the specificity becomes less. Why it is so? Because the sensitivity of culture is not at par of that newer molecular technique. But if you compare with CRS, composite reference, then the sensitivity both goes high. So the clinical outcome is very, very important to assess any the like the reliability of any test, whether it is NAT or culture.
Clinical outcome, when you treat the patient, we will get the clinical outcome. Suppose there is on a ingest basis, there is you want to change the regimen. Is it applicable for change the regimen? Cannot change na. Outcome, when you do it, get the outcome. The outcome, the result, unless outcome is that patient treatment and outcome. So unless their patient treatment is not there, we cannot get the outcome. So how will compare the outcome?
Yeah, I can also. When we compare anything, we compare with this. What is the standard of care?
Yeah.
Good. What is standard of care as of today? Like we have a drug trial. What is the standard guideline says? What is the standard treatment? How the new drug is going to give you a benefit? What is the standard of diagnosis as of now? And what is the new diagnosis method we're going to add on? I think that is should be our aim.
Right. No, in fact, in my view, the outcome for this, we cannot change the treatment based on what we are proposing, right? The primary objective is to see whether you are able to identify mutations which can strongly predict drug resistance, number one. And as a secondary outcome, since they are being followed on the standard treatment regime, whether those cases which gave the result that they had additional mutations and went on to the traditional treatment regime, the frequency of failed cases were higher in those cases. That will be the strong justification, if ever we reach that stage, that this is the method of choice which should be taken forward. So that's what I think. You cannot change the treatment, but yes, you will be much more informed in terms of why treatment failed, and then you will be able to justify or not to justify depending on how the data comes out. That whether it is a feasible approach. Yeah.
Can you do the host factor assessment? Which a bacteria, because why I'm saying that we are treating the patient with PFAS. There is suppose that 70% is the success rate. There are another 30% is the unsuccess rate. Why these people, group of people, are not responding? We want
So-
the answer.
So, sir, that's fantastic question. And as my, I'm not a microbiologist, I'm actually immunologist, and I do host responses to infection, and that's
right.
my domain. But I can tell you, if I combine with UDST and host factor, we are done. And nothing can happen because that's extremely complicated. And, despite me having a lot of leads, I'm still saying that it's very complicated. We only look for those cases where failure is because of drug resistance, but not because of BMI or anorexia or any other reasons. So that will complicate our analysis. So I think we'll restrict it to drug resistance based failure in treatment outcome.
I have small queries. Is there any inter-machinery variable variation in detecting mutations? I mean, say, what machine you was, Madam is saying, Illumina platform, they have also sequencer. So,
Before we proceed, we are very clear. We are not dissecting any existing policy of government of India. I want to repeat again. We are not dissecting or debating or criticizing any policy of any government. Here we are to understand the pilot project. We are not changing regime. We are not touching CTD. We are not challenging or contesting any technology. Our outcome from our mindset is very clear and simple, very humble. That can we do a pilot project? Be it now you call it as operational research, policy research, whatever name tag we want to give it. So now we can proceed keeping this in mind very clearly. Thank you.
I think answer is yes. So no doubt.
So you're asking a question, right?
I was asking different platform. Is there any variation?
About the sequencing platform, right? So, right. So,
I just
so
asking my
ideally we
query.
should stick to one platform. That would reduce any sort of in the beginning at least. Because right now the most important thing, see, I think what Nandeshji said is, the whole pilot would be to test the feasibility. So that's a primary goal of, not to change regimen or not to change anything, and completely to see whether this is going to be feasible at a large scale. That's all the whole purpose is. And for that we need to have the same platform, the uniform SOP. That means if there are multiple centers doing the sequencing, they all must follow uniform SOP, starting from sample collection to transport to processing. Everything has to be based on a single SOP. So that need to be maintained.
And if this pilot project that we are discussing is already done, then our job is done. My job is much easier today itself. The conclave, we achieved the aim. But I feel and I know that this is not done. Because often we mistake that when we use word policy, we are here with a danda and say, this is not right, this is not right, this is not right. No. When we touch policy, we say this is not right, this is the solution. Let's do a pilot, check it, collect the data, analyze the data. Data is saying it is not feasible, close the project. Somebody has to take action there. Somebody has to fund there. Somebody has to do some effort there. That's what our pilot project means. We are not here to challenge any policy which is existing.
I think it's an innovative, most novel. I think it's one of the maybe game changer for the future.
And yeah, and I think one of the
Same
things
thing
that
happened in the molecular technology.
So it is again over the decades it will change. I think that after 20 years something new can add on.
absolutely right. So that's the whole point. And if I may say, what I believe is that any such pilot studies, more than giving answers, it will tell us where it can go wrong. That's most of the, most of the pilot studies do. Then you figure out, why it went wrong and you go ahead and correct it. That's how it works.
So,
But
so my question, so far the evidence of literature says nowhere it has gone wrong.
no,
Nowhere it is, no literature says that it has gone wrong.
I don't think in India it has gone to this scale.
Nowhere,
Yeah,
nowhere
no,
world
no.
it has gone wrong. It is
Ah,
given much
no, no,
evidence.
actually there are places, I think WHO has done some places. I think South Africa and all, they are they are supporting, I guess. Yeah.
Without the pilot study conducted in India, NTG will not allow for.
Exactly.
Yeah,
So,
exactly.
see, that's what some.
I'm a member of the NTG.
Exactly.
Will not allow for the.
And they should not also, right? So they should not also, because this is an untested thing in the country. So
What happens to our
absolutely. So it has to be tested whether, without affecting the current systems. And that's actually the most important point, right? How, if we do this, how can this strengthen the NTP's current programs? So that's open, to all. How, if we implement this, and if we do this pilot study, how can we use it to strengthen the existing NTP, strategy?
I think first we will have a multi-centric. You have done already in Northeast. You have touched. So going to touch in the mind. Also next is the East zone. All the zones should be taught. Then all the population should be taken in account, and we have to find out what is the whether we get the best result or not. That way we can the whole country for a year. We have to like a sample from different zones, because the genetic condition, environment, also everything is different. So I think your proposal should be in future also. You will touch every zones of the country, our country. Then we can have.
I think it's a pilot project. It should start somewhere, and it can be extended to as the funding agency needs. I think this all depends on how much fund, how much logistics you have, how much can be done, and how. I mean, there is a possibility. I mean, it's all so far there's no failure in such projects.
Keeping the experience of those problems we faced regarding this first line LPA, second line LPA or culture samples, I've already told that we have to ensure that we have to overcome those problems while implementing this one, so that from the beginning we will not face that challenge during the pilot or during upscaling it to the total program. That is it.
Okay. So, see, another challenge is about the cost associated, right? So now, if you look at the kits, the targeted NGS kits, it's actually been approved, multiple kits are approved by WHO. For them, they have done the sensitivity, specificity studies based on, I think, PDSP. And if you look at it, probably one of them only will be useful, currently available probably in India. And that actually exaggerates the cost. But if I am right, there are multiple other Indian startups may be involved already in the whole in this game. But they're probably not approved by WHO, and I'm not sure they are even approved endorsed by even ICMR at this point. Probably there may be something going on. But in such a scenario, how do we, but advantage of having Indian startup is that we can bring the price down. So what's the take on, that particular playing field? How do we make use of the startup, that ecosystem to bring down the price, make quality products and bring down the price for this?
We try for the indigenous product, Indian like Civinat and Tunat. So Civinat at that time the cost is around 800 something. You calculate in the dollar, Johnson probably.
Those things to be
So that when come to Tunat, it is 150 rupees something like that. So if some Indian company will come with this, that will helpful. Even if we are implementing in the country, in future we also require more number of periods. So it is a time also the Indian company should come with that will also will be less costly about the reagent or.
I think this needs validation and WHO endorsement. I think that's more important.
So every company is coming there,
That's
got the
what-
validation. Isomer is doing validation. So that can.
Sir,
This cost point reminds us, uh, HHMI had organized a meeting in South Africa, 2010, 2011, and there was a lot of discussion on Gene Expert and how much per sample test costs. And Barry Bloom, some of us may know, he was a very famous microbiologist at Harvard University. And his statement was, and a lot of policymakers were sitting in the crowd, and he said that whatever cost you say is peanuts. If you look at total cost that the state overall bears, if you have a TB patient that goes undiagnosed, and if drug resistant goes undiagnosed, right? With time, things evolve, right? You have TrueNet, which brought the cost so low, right, that you don't even think about that there is a cost involved, right? So I think while this is in infancy, the whole the targeted NGS stuff, so with time, things will change and improve. And this, you want to say something?
On this cost, sir, I can say on the public forum, Indian Institute of Management, Ahmedabad, there is a professor, Dr. Vishwanath Pingley. He works on health economics particularly. And he has a published paper on cost of inaction for tuberculosis. He has published the paper. Now, this has a math model. He has done the global study, and I have not deep dived into it, neither am clinically so sound that I can discuss that. But I would recommend to once have a look on the paper. And automatically we will understand what Dheeraj ji said, that if we miss here, then how much we pay there. Simultaneously, we are working on the similar principle for cost of inaction in cancer. As generally we will agree that if we can identify a person with the stage 1 or nearby, then the cost for that person, whoever bears the cost, whether it is out of pocket or whether it is government or whether it is by universal health coverage, the cost is much lesser than a patient gets detected at stage 3 and above. So this particular math modeling for TB is already done in place, but somehow that study has never, take the place in the decision-making ecosystem. So somebody can say, yeah.
One thing I can say that in cancer, it's not going to transmit one person to other person. Here, the drug resistance is going to multiply, and also the cost effect. It's a recurring. It's a future cost is enormous in the country has to face if you lose a patient untreated, goes patient untreated properly. Health treatment.
So before we come to the conclusion round, I think if there is any question from the audience, we'll be really happy to discuss those as well.
This is a question to Mr. Nandis. Sir, Government of India is often asking proposals from the common citizens for giving proposals for this Viksit Bharat. So in also TB, when we know that the linezolid is a drug which is causing myelofibrosis and optic neuritis, it is used in Vipalam and as well as in AOL. So why don't we take up a project for tedizolid, which can be used for Vipalam and the other regimens, and it remains as under-evaluated drug also. This is my question.
Yeah, thank you. As I said earlier, sir, which project we take is probably decided by the group of clinicians and the scientists. So once today your proposal, definitely my team has already noted, but I can tell you one thing, that we believe in taking one need, actually drill down up to the ground, to the patient level, do something action. Failure, success, we really don't factor when we start. Definitely, who wants to fail? Nobody wants to fail, right? Everybody wants success. But we still want to finish one job, finish one project, complete it, hand it over to the government, see whether it is possible, not possible, and then take it up. So, good suggestion. We'll definitely think.
Thank you.
Sir, is there any evidence based on the treatment, based on your sequencing based a treatment protocol available?
Oh, you mean for
What I mean to say,
regime?
yes, what I mean to say, suppose we patient get the report of sequencing. Being a clinician, can we implement the treatment or any evidence available at present?
I think, I don't know if private hospitals do or not, but certainly I cannot be envisaged doing that. They're doing based on genome sequence. If you identify new mutation, yeah, Camilla is doing
So
it.
But he cannot go beyond the government norms. But
The government gives guidelines for, sir would know better, for mono, poly, and
Yeah.
multi-drug resistance. So the guidelines are always there that if you identify resistance to INH alone or rifampicin alone or any other drug or multi-drug or poly, not multi with rifampicin, what should be the treatment? But what we are unable to do now is to diagnose this resistance early and adequately. So if we are able to diagnose, will we not be able to use those regimens which are already existing in the guidelines?
PMDT guideline is there.
Yeah, PMDD guidelines are very much there. We are not able to identify the resistance. So what we are
Madam,
proposing?
guideline is defined based on a molecular testing. Whether guideline is available based on sequence testing.
Sequencing that.
So this is also a molecular, isn't it? I mean, molecular is
Sequencing is
genomic.
also molecular.
Genomic. So it is a higher resolution. So why should it be considered as an inferior evidence for initiating that treatment? So we are, with molecular, you are able to find very specified mutations. With genomic, you have larger resolution, greater resolution, and you can identify many more mutations. You're screening the whole genome for those targeted genes. So the evidence is a higher grade evidence. So why should there be hesitation in starting treatment? What is there in the guideline for that particular drug resistance?
Suppose a patient having as our molecular based CBNet RPO gene positive means we are thinking that a rifampicin resistant we can start MDR treatment. Suppose gene sequencing identifying other gene is a MDR regime or as a prove as a MDR or a rifampicin resistant TB bacillus. Can we, based on that, we can put in the MDR regimen?
The scope of this, out of the scope of this project, discussing.
I think
So at the, yeah,
But one thing I can say, these are guidelines. Guidelines are not legacy or acts. So over and above, one can have extra treatment if the committee feels with the various, when there is multidisciplinary committee and group of pulmonologists sit and decide that this patient may be given an extra drug. So that is nobody said no to it. It's always a guideline. It's never said that it.
That's why I'm asking any evidence available to based on sequencing method or based guideline.
We're not changing this.
No,
Sequencing is done in very few setup. So they are using, they are changing the treatment at their own level. So those are not yet guidelines. And in fact, the implementing or this having this type of project is the secondary output, I would say, to gather the evidence. Then only we can go for guideline.
No, it may not be guideline.
So
but
not
any,
at this stage, there is no guideline based on the sequencing.
Right.
But yes, there are many evidences are there that sequencing, on the basis of sequencing, the treatment should, if changed, then the outcome is better. That evidence is definitely there. I think Hinduja is one of the example in India who they are doing since so many years.
That means there are evidence available based on sequence-based treatment.
Even South Africa example, what was discussed, that Fatini Island example, that was not picked up by CBNet also.
Okay.
And patients were having tuberculosis. And it was sort of outbreak. And it was diagnosed by the sequencing. So those type of small pockets of evidences we have. Now it has to be gathered in such pilot projects. Then only the guideline will be built up.
Thank you.
I can add also, these guidelines mostly for field conditions. In generally, it is there. But over and above, when suppose patient is very sick, are you not going to extend your our treatment for intensive phase to maybe 4 months, 5 months? We do it practically, or it's all different. The guidelines for field concern, as we everybody know.
Individual person, individual patient. But for the program condition, it is very different. Unless the country take as a modality, sequencing as modality or diagnostic modality, then we will think for the what next regimen we can test that for. So time will tell.
We believe, firmly believe that the pilot program that we are taking at the steps actually is in that direction. But we'll have to hope and pray that it succeeds so that we go in that direction. So I think that's where we all are. If there are any further question?
What should be consensus?
Yeah, so yeah, I'm kind of, I believe we had enough discussions and agreement, some disagreements, but I believe we come to a consensus that getting into a UDST using PNGS should be a way forward, and we do it in parallel to the existing system so as to develop sufficient proof of concept that this is a feasible and more useful way of doing a drug resistance prediction for TB samples. Yes. Sir, those are implicit to it. The moment you say that we are taking it up, that is part of it, because it cannot happen without those training, those development. That has to happen. So yeah, absolutely. Yeah.
Is very, very important to chalk out the roadmap.
Something which I'm sure that has been partly
Unless
worked
that is done, nothing is going to happen.
Yeah, so we can start from that side on the concluding remarks.
So definitely we'll plan a joint action committee type of meeting with AIMS Bhubaneswar. So how we can go ahead, because they will be our knowledge partners and we will be the implementing agency. So you have to look after everything that I've already described, that feasibility, simplicity, all these things has to be taken into account so that it will not overburden anything, our existing activity, existing those healthcare workers, and based on their knowledge also, we have to ensure that everything goes.
I don't agree that we are the knowledge partner, you are the implementation. We are together actually. We are all jointly do it all. We are not going to get any treatment. We are together in the same boat. So
Yeah, we like the spirit, so that should be the spirit actually. Fantastic.
Teamwork. So if I am there and do my job, you are there, you do your job. So that means it's a teamwork.
Thank you.
As far as Odisha is concerned, Odisha is always in the top as far as tuberculosis implementation is concerned. So maybe any new drug is implemented. So within a week, whatever the government of India implement, within the 7 days, only Odisha will be implemented. So hopefully also in tuberculosis, any project, any year, definitely the institution will help. May it be AIMS or may it be the state medical college, wherever you want, you can do, even if to that extent, which is not possible in India also, is the FAST center. SC Medical College, Pulmonary Medicine is the FAST center where we have did the modular OT for surgery of the TB patient. Because commonly TB patient, they are not cardiothoracic people not allowed to do a control surgery. So we have done in Odisha, because it is also specially also the secretary has approved that in a 2 crores 20,000 rupees, 20 lakhs rupees, and we have approved, and the surgery for TB patient is going on. So also in every case for tuberculosis, the state will support.
Exactly 30 years back, this government, I was sharing that exactly 30 years to 1996, the same pilot project was started, I think, on the funding of TB for dots. So Odisha has taken the forefront of
97,
that.
90,
It
we
is
are in the
exactly
that
36
that
I
project.
said that why did it started like this? So not in detail.
So I just conclude by saying from my side that we all have realized the need of it, and we also have discussed that it is feasible, and the commitment of Odisha already the examples are there, various examples are there, and on top of that, Dr. Pradhan has also given commitment from his side. So it's a wonderful thing to proceed forward. So it is, it should go ahead.
So from PRF, I can definitely reiterate that we are not challenging any existing policy, or we are not saying any good or bad, but we are ensuring that whatever best we can do, come up with something, implement it with the stakeholders, and we remain in the backseat just to ensure that we do our job right. We don't intervene in the clinicians, we don't intervene with the scientists, let them do their job right, and we do our job right. So we can commit that once we see the feasibility, we definitely deep dive a little bit and see the modalities also, whether that is feasible or not. AIMS, Government of Odisha, everyone, the mahol that I'm feeling, it's very positive. So maybe we can work out at the concept level first, derive some estimation, discuss more, deliberate more, maybe have a Government of India participation also, ICMR participation also. And then once we have a rock solid conclusion of how we go forward, we are ready to move ahead.
It was a fantastic, panel discussion. And of course, the point is that when we have an idea, we know all the positive sides of that idea. But then when we, have this kind of discussion, we also come to know that what are the, what we should expect when we try to, implement it. So that's essential. Then only we can really plan, right? To expect what are the challenges that we have to, and we can make it better. So I think this would help to finalize or the plan for the pilot study.
Thanks, Anish. Thanks, everyone, for your really valuable points. I think they are all well meaning and well recorded, and that will help in setting up the roadmap, the purpose for which we are doing this discussion, the roadmap for implementing this pilot program. And really thank all of you. And I believe we have the consensus that we need to take it up as a pilot program in Odisha. And let's have it in this way around, that it's not coming from Government of India. Once we establish Odisha, then Government of India takes it up at a national scale. So that's something which we believe. So thank you to the audience also for actively being, participating in this discussion. And we hope that we all had very enriching experience in terms of knowing the ground realities of challenges that we face in diagnosing TB, and how do we address it using the newer technologies. Thank you very much.
Thank you to our esteemed panelists for such an insightful and engaging discussion. I would like to request all the panelists to sit back for felicitation. So I would like to invite Dr. Jitendra Kumar Patra, Associate Professor, Department of Pulmonary Medicine, SCB Medical College, Cuttack, to facilitate Dr. Dheeraj Kumar. Dr. Rohit Kumar, sir, Professor and Head of the Department, Safdarjung Medical College, to facilitate Sri Nandish Ji R. Pethani. Dr. Sonali Sarkar, Professor Community. Dr. Manoj Kumar Panigrahi, Professor, Department of Pulmonary Medicine, AIMS Bhubaneswar, to felicitate Professor Dr. Manoranjan Patnaik, ex-professor and head of the Department, Pulmonary Medicine, SCB Medical College, Cuttack, and ex-chairman, State Task Force, NTP, Odisha. Dr. Sudarshan Pothal, Chairman Odisha State Task Force NTP, Professor and Head of the Department of Jagannath Medical College, Puri, to felicitate Dr. Prashant Ragam Mohapatra, Professor and Head of the Department Pulmonary Medicine and Critical Care, AIMS Bhubaneswar. Dr. Vishwa Ranjan Mishra, Professor and Head of the Department of Psychiatry, AIMS Bhubaneswar, to felicitate Dr. Argya Pradhan, State Tuberculosis Officer, Odisha. Dr. Sorin Bunia, Professor, Department of Pulmonary and Critical Care Medicine, AIMS Bhubaneswar, to felicitate Dr. Anish Kumar. Thank you, everyone. Thank you, everyone. We will now have a break for a 15 minutes tea break. Kindly reassemble in the hall after 15 minutes for the next valedictory section. Thank you.